Hello, everyone. Good evening. You are welcome to my live session. My name is Dr. Wisdom. This evening, I'm going to be introducing another series of several series here to come. This evening, our topic is headaches and associated disorders of neuro-ophthalmic origin. Headaches and associated disorders of neuro-ophthalmic origin. So we want to look at the concept of headache and then originating from the neuroanatomy of the body, and also want to also look at associated disorders that accompany headache, and then want to be able to demystify them and then bring them to a clinical setting so that each and every one of us will be able to make headway in um, improving our clinical dexterity. So before I begin, I want to dedicate this video to the HOD of Imo State University, Dr. Magnus Osonwu. He taught me this course when I was in 500 level, I think visual analysis. He taught us on headache, and he did a very wonderful job in explaining the concept of headache, and it's on this on what he built that I've been able to add a little quota. So my kudos and shout out goes to Dr. Magnus Osonwu, the HOD, the proactive HOD of optometry in Imo State University. So quickly, what are we going to be looking at from this series? It's going to be a series of several clips. So I will just do the introduction today and introduce a little topic, and hopefully subsequently we'll add another layer to the several layers I will be adding for us to be able to decipher what headache is in a clinical setting. So we are going to be looking at a whole lot of things. We are going to be looking at important clues. We are going to be looking at the trigeminal nerve and also pathologies affecting the trigeminal nerve. We are going to be looking at classification of headaches, the types of headaches. We'll be looking at migraine, the types and the treatment. We'll be looking at cluster headache. We'll be looking at the SUNCT syndrome, the SUNCT syndrome. We'll also be looking at paroxysmal hemicrania. We are looking at ice-pick headache. We'll be looking at cough headache, venous sinus thrombosis, thunderclap headache, headache and ocular diseases, facial pain disorders. It's going to be all this and a whole lot more. So I want you to stay tuned, stay glued, don't miss any session. Invite as many professionals you can invite so that we all journey together in building our clinical dexterity. Having said this, let me begin with the basic concepts in headache. So what are the basic concepts? I want us to know that the term headache is defined as a pain, any pain in the part of the head. So whenever a patient is having pain in the head, what we call it, or what is called, is headache. So any pain in the head is called headache, but not any pain in quote, but most times whenever a patient has a pain in the head, we want to call it headache. It is the most frequent health complaint encountered in the clinic. A headache is one of the most frequent things you will hear in the clinic. A whole lot of patients come, they say they have headache, and as a primary care physician, you are most likely to be the first point of call whenever a patient comes with headache. So as a optometrist, you are going to be working with the ophthalmologist, you are going to work with the neurologist to be able to decipher why this headache is there, and then bring out a possible treatment plan. So it is good that as primary healthcare workers, we understand the concept of headache. We can pinpoint the types and then know when to refer and know when we can easily handle such a case. Are we together? And from statistics, it shows that 90% of individuals or more have had headache or is going to have headache. So statistically, 90% of individuals or more have had headache or will eventually have headache. So you all will agree with me that in your course of life, you have had headache before, and you want to know what really causes headache. There are people who have severe kind of headache, and most times can be recurrent. So we want to also know why this is happening. And again, I want you to note that the trigeminal nerve it supplies the eyes richly, and the trigeminal nerve is a very important um, um, subject we must look at when dealing with headache, because it is it is the largest nerve, and then it richly supplies the eyes, and it is both a sensory and motor nerve, in the sense that it can send um, sensory sensations, and also it can innervate a muscle to move. So it's both a sensory and motor nerve. Are we together? And then the trigeminal nerve has three branches, which is the ophthalmic, the maxilla, and the mandibular. These are the three branches of the trigeminal. That's why it's called tri. Tri means three. So it has three branches. The ophthalmic nerve, of course, innervates the eyes. The maxilla innervates the part of the body, this part, and then the mandibular, the mandibles, it innervates them. So we want to also know how this trigeminal nerve can result to headache. We're going to be looking at all this in due course. And again, the ophthalmic and maxilla are sensory nerves, while the mandibular is a mixed nerve, in the sense that it is both a sensory and motor nerve. Also trigeminal neuralgia is a condition whereby a blood vessel compresses on the trigeminal nerve, resulting to pain. So we also want to be looking at trigeminal neuralgia, and then how we can prevent it, possible causes, and then the treatment plan. All this we'll be looking at in this session. So that is that for the introduction. The International Headache Society has published about 176 different types of headache. In other words, they have classified about 176 different types. So this lets you know that headache is a serious thing. It is a serious thing in Africa, it is serious in Asia, it is a serious thing in Europe. So the International Headache Association has come up with 176 different classification, different types of headache, and it can be more, because the more research goes on, the more we find out that there are different types of headache unveiling as the day goes by. But then we are just going to focus on very few of them, the ones common in our region, and then we tackle it. So due to the complex nature of classifying headaches, it is expedient that a thorough case history is done, because headaches are complex to understand. So a thorough case history should and must be done in order to be able to let you know what is going on. And most times, if not every times, it will just give you a clue on less than 30% of what is going on. But then the case history is very important. It tells us what to do. So there are certain cues or certain indicators we should look at when dealing with headache. And later we'll discuss this for this session, and then we'll call it a day for today, so that next session I will now begin to build more intensely, so that we can understand and grasp what I'm talking about. So there are important clues we have to look out for in headache, in finding out, or try when you are doing your case history. There are important clues you should point to, or you should direct your case history to. It gives you a clue on what is going on and the type of headache being discussed or being presented to the clinic. The first clue is frequency. How often does this headache happen? The frequency has a way of telling you what is going on. The second clue is the location. We want to know, where is this headache? Is it temporal? Is it frontal? Is it occipital? The location of the headache is also very, very important. Also, duration of episodes. How long does each episode last? Does it last for a few minutes? Does it last for a few hours? Does it even last for days? For some people, they can have headaches for weeks. So we want to know the duration of every episode. It gives us a clue on how to tackle headache in a clinical setting. Also, the intensity of the pain. The intensity of the pain can also let you know what's going on. If it is mild, it has a meaning. If it is throbbing and deep, it also has a meaning. If it is severe, it also has a clinical significance. So we want to know the intensity of the pain, and then know what to do next. Also, the usual cause. What cause does it follow? Does it come maybe before you fall sick, or does it come after you fall sick? What cause does this follow? If the patient can be able to tell the clinician the usual cause, it goes a long way on letting us know what is going on. Also, the triggering factors. We want to know what are the factors that trigger it. For some people, stress triggers headache. For some people, after prolonged work with their laptop, they come down with headache. For some people, if they've not slept well for a quiet period, for a number of time, maybe they have overworked themselves, they come down with headache. So we want to know what the triggering factors are, and we want to be able to pinpoint them and write them in simple terms that, oh, this is what triggers it. And for you to be able to say this is what triggers the headache, it should have happened at least 2, 3, 4 times so that you can now note the pattern that, okay, every time I overstress myself, I have headache. Or every time I come short of malaria, I have headache. Or every time I work overtime, I have headache. Every time I work with the system for long, I have headache. So triggering factors are very, very important. Also, the family history. We want to know the family history of headache. Is there a family history? Does it happen in the family? The father, the mother, the brothers, the sisters, just the family. We want to also get a good view of that. The family history can tell you if what we are dealing with is congenital, if what we are dealing with is acquired or induced by something. So we want to know if there is a family history. These are important cues in case history of finding out what is going on in a headache, and also the laterality is also important. And finally, the mode of onset. How does it start? Does it begin with aura? Does it begin with loss of vision? Does it begin with transient loss of vision? Does it begin with sudden loss of vision? How does it start? So it gives us an important clue on what is going. So these are just one of the few clues, and it's not related to this. So in your case history, if you can note these clues, if you can be able to connect the dots, connect the lines, you will have a good view of what is going on in headache. So this is just a brief introduction of headache, and I'm hopeful that in our next class we'll begin headache proper. In our next class, we'll begin a proper look at it. We'll begin to look at migraine. We'll begin to look at the types of migraine and what induces migraine, how we can treat migraine in the clinical setting. All this and a whole lot more will be discussed in the next class. Stay tuned. My name is Dr. Wisdom. Don't forget to like, comment, subscribe, and share this video. I hope to see you in the next session, and I'm sure you have a lot of questions to ask. Please drop them in the comment section. I will attend to them um, after now, and then give you a positive feedback. Thank you for joining us, and have a nice day ahead.